we're going to start by the first one, which is paged by a nurse, right? And then the paged by a nurse for hypertension, okay? So what happens is, you're going to be paged and the page is going to say, patient X is hypertensive, and then I don't know, they're going to mention like 200 over 130. Okay, you're going to get this kind of page. All right, and the reason they will page you, by the way, sometimes they will page you even if the blood pressure is like 130 over like 90. Okay, do you know why they will page you? You know, like why they will tell you, hey, the pressure is 130 over 80, even though like you're not going to do anything with 130 over 80. You're just going to watch. Anybody has an idea, like what's the logistics?
Because of medical liability, probably they don't.
Exactly. There's some sort of medical liability for the nurses. They can't make these decisions. So they have parameters where if the blood pressure goes above a certain point, they have to page you. And then they will write a brief note or they will tick a box called MD aware, essentially. That I told the MD and then they're aware of this. Okay, so they tick this box and then their liability is over, right? It's not on them anymore. Okay, if the patient gets a bleed, it's not their problem. Okay. So what's the first thing you want to do? Patient is hypertensive. What are you going to do the first thing? What do you think?
Check his medications.
Recheck blood pressure, probably.
Yeah. So first thing is what I do is you want to go and assess the patient physically, right? You want to physically go, because a lot of these times you're either overnight, you're either sitting in the resident room and whatever the call room, or you're sitting in the resident room, you're writing your notes, and then you get this page, patient is hypertensive, okay? So what you're gonna do, at least what I do is, what I learned to do is the first thing you wanna do is to measure again, right? So measure blood pressure again. And you wanna do it the automated way, right? There's the automated machine, you bring the machine to the patient's room and then you measure it yourself, okay? So, the blood pressure might be normal, in which case, if it's normal, then you're done, right? That's it, it's over, okay? Or the following measurement might be like, I don't know, again, 200 over 140, okay? What are you gonna do with this? Just gonna take you step by step. Like we measured it again, it's 200 over 140.
Ask if the patient's having any symptoms. Just a quick history and physical exam.
Quick history and physical exam. So yeah, that would be correct. But what I learned is really what you want to do is measure again. Even though it's measured one time, I feel like just measure it again. Sometimes it's an error, okay? So again, if it's normal, then you're done, right? If again, it's like, I don't know, 190 over 130, then what do you think? How else can you troubleshoot it? I'm just gonna, before you dwell into what to do to the patient, there's more troubleshooting you can do. Anybody has ideas?
Use a different machine.
Use a different machine. What kind of machine are you going to use?
Manual blood pressure machine.
Good. So the things you can do to troubleshoot this is, one, measure manually. So you can measure manually. You can get it manually. Okay. What else? Anything else can falsely elevate?
Use a different
arm.
Different arm, different cuff. Great. So different arm, right? 3, cuff might be too small, right? So these are the things you think about. Is the cuff too small? Maybe I'll look at the different arm. I'll let this different arm, use it with caution, right? Why? Because if it's different than the other arm, like let's say you measured it on the right, it was different than the left. It's like higher on the right than the left, or higher on the left than the right. What like directly?
Dissection. What is this?
Right. You're thinking about dissections, right? So, yes. So always think of that, but really these things are, you're gonna do these, okay? And then, you know, if you end up seeing that the blood pressure is normal on the after these measures, then again, you're good, right? You changed the cuff, you did everything, you're good. If you did all these things, and then now, you know, your measurement is still like, I don't know, 200 over 130. Now you're like legit, right? So now you have a really high blood pressure, okay? So what do you call this in your mind? What is this called when somebody's pressure is 200 over 130?
Hypertensive emergency.
Emergency.
Or
Anybody have
emergency, depending on the symptoms.
urgency or emergency, right? So in your mind, this is hypertensive urgency. Let's just keep it at urgency, okay? Which means this needs treatment, right? This really needs treatment. So you really need to think about what do you want to do, okay? So again, before you start giving medications, right? Like everybody might rush here. Everybody might rush to say, give the patient some like hydralazine or something, and then, you know, see what happens, like check the blood pressure again. There are really important questions you have to ask yourself, okay? And before you do anything, what you need to ask yourself is the patient hypertensive? Does he have a history of hypertension, okay? And if so, what's the baseline of the patient's blood pressure? Okay, so that's really important. And then finally, what medications is he on and were they given today? Because a lot of times what happens is nurse held the medication wasn't started, blah, 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 something happened, okay? So you want to go into the system, you want to see the medication scheduled, and sometimes just a tip or a note for you guys, you might see like in the medications that, you know, the patient is on like, let's say amlodipine, 5 milligrams, okay? And it says next to it scheduled, okay? The medication is scheduled. Remember, this does not mean that the patient took the medication, okay? You really need to kind of investigate, you know, click in it. Was it given? Okay, given, and it will mention a date and time. Okay, you really want to see if this medication was given or not, because it wasn't given, right? What are you gonna do? Right? So if the medications, like, you have either two options here, okay? That, you know, either all meds were given, all his hypertension meds were given, or some or none were given. So if some or none were given, what are you gonna do? Easy, right? Give the rest. And then see what happens. Because, you know, a lot of the times people go into hypertensive urgencies when they stop their medications abruptly, okay? And you just need to give them back the medications, especially again, if they're asymptomatic. But, you know, where you get in trouble is if all medications were given and, you know, you still have a guy with blood pressure of 200 over 130, even though all medications were given, okay? At this point, you're gonna do you're gonna do a brief history, okay? Plus, what's the important thing to do? The physical exam. And what's the important physical exam to do?
Mental, like neurological exam to see if he's having a
Neuro
stroke.
exam.
Yeah.
Exactly. So neuro exam here is the most important thing, okay? Why neuro exam? Why do we say neuro exam is the most important thing?
Strokes.
Strokes. Are you worried about a stroke as a result of hypertension? What do you guys think? You can throw it in the chat. Are we worried that the stroke is a result of hypertension, or are we worried that there's a brain bleed as a result of the 200 over 130? Or what exactly are we worried about? Why do we say stroke? Okay, so I'll give you the answer. The answer is both can be applicable, right? So both as the stroke as a result of hypertension, or stroke as a result of or brain bleed as a result of hypertension is applicable. But that's not the main reason. The main reason is because people, when they get a stroke, okay, what happens when somebody gets an ischemic stroke? Like, let's say somebody gets an MCA, ischemic stroke. What's going to happen is there's a part of their brain is not getting enough oxygen. Okay, so that area is going to start infarcting, and as a result of that, as a result of the stroke, they're going to have hypertension to compensate for that loss of tissue in the brain, to try to get that blood to that area because of low cerebral perfusion pressure. So low cerebral perfusion pressure at any direct area is going to indirectly induce a hypertensive episode. Okay, in those people, let me ask you a question. Somebody shows up with a stroke and their blood pressure is 200/130. What are you going to do?
I want to keep it that way, or not lower it too much. Yeah.
Exactly. Keep it that way. Keep it that way. You have up to 220. You keep it up to 220. What do we call that? We call that permissive hypertension. Okay. So very important for you to do a neuro exam, because this patient might have a stroke and this is just their compensatory mechanism. So you really don't want to give them labetalol at that point, because you're just going to worsen things. Okay. So just keep that in mind. So I'm just going to keep it here. Keep in mind compensatory hypertension secondary to stroke. Okay. So if you do your neuro exam and if anything is wrong, what's the next step?
Head CT scan.
Exactly. So you're going to order a head CT. And remember, this is going to be ordered as stats. Okay. What else?
ECG.
No.
Oh, no.
Somebody is having neuro symptoms on the floor. What are you going to do? Yeah, you're going to get a head CT stat, but aren't you going to call neurology? People are going to...
Neuroconsult.
Neuroconsult. Okay, good. But how do you expedite these things? So every hospital, like let's say somebody has a STEMI. Yeah, you can call a cardiac consult, but you want to expedite things. So every hospital has expedited codes to get things, right? So you're going to call it something called a code stroke.
Stroke code, yeah.
Yeah. So you're going to call a stroke code. And the way you do it, you call the operator and you say, can you call a stroke code to this room? Okay. Or you ask the nurse and the nurse is going to do it. Okay. And when you call a code stroke, it's an automatic neurology consult. It's an automatic head CT. Like everybody gets mobilized. They come to the patient, get to the head CT. Everything's just happening right away. Okay. So it's very important. Right. And then again, the most important part of this, without going into stroke management, is to know the last known well to the patient, right? And then, so you need to document last known well of the patient. When was the last known well before your neuro exam? That's also very important, okay? So now let's say, the neuro exam, was normal. Okay, so now what are you gonna do? So you do your exam, patient's 200/130, and they're like, they're not having a stroke. So now you want to do something, right? You want to give them some medications. So what do you want to give and how you want to give it? And how much do you want to lower it? Do you guys know? Again, these are important because what happens is that the nurse expects you kind of to know these things, and you'll be just starting. You've never pushed medications on the floor. You've never ordered meds. Maybe some of you have, but for me, for example, I don't know. I've never done this before. I showed up to the room, and then my resident, luckily I had a good resident. He walked me through it one by one. So I'll walk you through it one by one. So before you even push medications, remember in your mind. Okay, I want you to keep this in your mind. So do not lower it. Do not lower the blood pressure, okay, more than 20% of whatever baseline in 2 to 4 hours, okay? So if the blood pressure is 200, do not get it less than 160 right away, because that will induce a stroke. That will cause decreased cerebral perfusion, and it might cause a stroke, okay? So you really want to do it slowly, okay? So here you have options, okay? You're going to give medications. Here you're going to give medication. And the question for you, are you going to give PO or IV? What do you guys think?
Yo,
PO. Anybody has other options? Can you give IV?
Yeah, you can.
We give IV in emergencies, we give PO in urgencies.
I would give IV regardless, because you don't know at this point, you don't know exactly if this is an emergency or urgency, because the patient could have like an AKI, right? That's the other thing. So they could have like the creatinine is going up. You don't know exactly if it is an emergency or an urgency. You really want to lower it. You want to get it back to normal and then make sure it's good, okay? So let's say you want to give IV. What are your options? I mentioned
Nicardipine Iv Infusion.
So Nicardipine. So Nicardipine, I have to tell you, Nicardipine is a calcium channel blocker, right? That's given IV. It's like amlodipine, but the IV form. But Nicardipine is a drip, and Nicardipine requires ICU management because you have a drip continuously lowering blood pressure. You need to check the blood pressure like Q1 hour or continuous every 10 minutes or something, whatever, every 30 minutes. So, and it's titratable. They have to go up and down on it. So this you can't do on the floor. Okay, what other options? Antihypertensive. I'm sorry?
Nicardipine, maybe.
Hydralazine.
Nifedipine is just PO. You can't give it PO.
PO, yeah.
Somebody mentioned hydralazine. Yes, hydralazine. Okay, hydralazine is a direct arterial, is a smooth muscle relaxant, direct vascular smooth muscle relaxant. So it's arteriodilator, right? Hydralazine. Hydralazine will work on the afterload of the heart. It will lower the afterload of the heart, okay? So you can give IV hydralazine, and the doses you can give is either 5 or 10 or 20 milligrams, okay? What's another kind of option, if you know?
Vitalol.
Labetalol, perfect, labetalol, okay?
Yes.
So labetalol IV is another option, and this is either given 10 or 20 milligrams, okay? Well, the important part for you to know is you're going to order these medications to be given once. So you're going to order to give once in the EMR, in your electronic medical records. And the other thing to know about these medications, you really want to give them slowly when you give them, okay? Why am I saying this? You might think that now I ordered the hydralazine, the nurse is going to walk up to the patient and give hydralazine. And you will be wrong, because that's not going to happen on the floor, okay? Why? Because most hospitals have a protocol that these IV antihypertensives cannot be administered by nurse, okay? So you will see this, that, the nurse will tell you this have to be administered by MD. Okay, so you will need to go and you will need to push the medication yourself. The nurse will fill it up for you. So here's 5 milligrams of hydralazine, good luck. And if you've never done it before in your life, it's going to be kind of, nerve-wracking. Like, what am I doing here? I've never done this. Okay, but you just have to do it. Okay, and the way I do it is, you have the hydralazine syringe, right? You have it, filled with the medication, and then you hook it up to the IV. All right. And what I do is, whatever quantity you have here, I would give it in like 5 minutes, like slowly over 5 minutes. It's insanely slow. Okay. But you just have to do it. You'll be standing there for like 5 minutes, giving the medication slowly, pushing it slowly as the patient, like for the patient. All right. The reason is you don't want to give it push at once because it might really tank the blood pressure. You want to do it slowly. All right. So after you give the medication, and again, usually what I give is my preferred, again, this is Muhammad's preferred method is to give labetalol. I love labetalol, unless the patient is bradycardic. Okay. I don't like hydralazine. Why? What is kind of to remember about hydralazine?
Can cause rebound tachycardia, maybe.
Exactly. It can cause rebound tachycardia. Labetalol will block the tachycardia, but also because of this rebound tachycardia, somebody with like aortic dissection, if you give it's contraindicated essentially in dissection, because if somebody has an aortic dissection, you give hydralazine, you'll increase the shear stress forces, and then it will worsen the dissection. Okay. I like labetalol. If you can give labetalol, just give 10 milligrams of IV labetalol. Okay. Remember the PO form of labetalol. There's PO form. There's also hydralazine. The milligrams are very different. PO labetalol is like 100, 200, 400 milligrams. The IV is just like 10, 5, whatever. Okay. So after you give it, what are you going to do? So these are the steps, step by step, how to give. Okay. First, I will check blood pressure again before I give. Before. 2, give the medication. Again, remember, slowly. Okay. You're giving it over 5 to 10 minutes. Okay. Then number 3. All right. I'm going to check blood pressure immediately after giving. Okay. Then number 4, I'm going to check the blood pressure 5 to 10 minutes after. Okay. And then if you want to be, extra cautious, check in 2 to 4 hours after. All right. So this is what I usually do. This is kind of how you manage it. Okay. Then you see the outcomes. All right. So now, let's say you did all that. Okay. Then after like an hour, you get another page. Patient X is hypertensive, blood pressure 200 over 130. Same patient. You're already given labetalol and something, and now the blood pressure again is like 200 over 130. Okay, what are you gonna do? You're gonna go assess, and then you're gonna do, your physical exam, and then you're gonna do the cuff checks. You're gonna recheck. You're gonna do all the things that we did initially. Okay, and then what you can do is give another dose of whatever you gave, of your agent of choice. My recommendation is not to mix. Like if you gave labetalol, stick to labetalol. If you gave hydralazine, stick to hydralazine. If you gave 5, give another 5. If you give 10, give another 10, or give 5. Okay. And then, at this point, it might just work. Then you're done. But if it doesn't work, then what do you do?
ICU admission.
Perfect. So now you're edging towards the idea of ICU. Okay. So now this patient really requires ICU monitoring, because now the patient's blood pressure is not responding to multiple IV doses of hydralazine, labetalol, whatever. Okay. But remember, for this, you need the attending approval. Okay. So you can't just send a patient to an ICU. Okay. And at this point, really what I like to do is to get labs. So now you want to do an EKG. Now you want to, do a CBC, comp. and then, troponins, right? And in the ICU, as somebody mentioned here, you can use either nicardipine drip. What else? What's another drip that can be used here? Anybody knows another hypertensive, antihypertensive? So
Nitroprusside.
nitroprusside, yes,
Nitroprusside.
good. Nitroprusside. So nitroprusside drip. Okay. So remember, these drips are titratable to the blood pressure. Okay. After all this is happening, once you transfer the patient to the ICU, what's an important thing you need to do? Housekeeping thing, or like logistical thing. Now you're sending the patient to the ICU, right? What do you need to write? Remember, transfer notes. Okay, so you need to write, or sometimes some people call it an event note. So you really need to document exactly what happened. Okay, I suggest that anything you do for the patient that is outside the typical plan, like right here, the stuff that we did in the beginning, you really want to write an event note. I was paged by the nurse at blah, blah, blah. I gave this medication. I did this and that. Okay. So anything you do, it's good practice to write an event note about what's happening. Like, why did you do what you do and what you did? Okay. And then you transfer the patient based on the transfer note that we kind of. Cool. Any questions about this?
Just a question. What is the threshold for, acting upon blood pressure? Is it 120 over 100, 180 over 120, or is it higher?
Yeah, once it hits hypertensive urgency, whatever the definition is, like usually, 180, systolics 180, or over 120 is like, kind of the threshold to start giving these IV meds and stuff. If the patient blood pressure 160 over, don't act on these 160s, unless it's hypertensive urgency and you feel like you really need to give, don't do it.
Thank you.
Cool. I think this session is gonna kick us out.